Hi, welcome to Guts and Glory, the podcast which delves deep into the complex world of gastrointestinal and HPB disorders. Join me every month, wherein we unravel the mysteries of these complex issues in candid conversations with leading experts who share their experiences, tackle contentious topics, and provide cutting edge insights. I'm Sadiq Sikora, and this is Guts and Glory. The guest is Dr. Subash Gupta. I'm sure most of us in India know him. He's a pioneer in liver transplantation, especially the living donor liver transplant. And currently, he is the chairman of the Max Center for Liver and Biliary Sciences at Max SuperSpeciality Hospital. But that's his formal introduction. So we've known each other since, I guess, from 79 or 80 onwards. Uh, he's the 79 batch, right, Subhash?
Yeah.
We have the same alma mater. We graduated and trained at All India Institute of Medical Sciences. And it's interesting that at this point, I enjoy the reflected glory and tell people that we have worked together simply because he has made such fantastic steps and tremendous achievement in this field. So he is instrumental in training this current generation of liver transplant surgeons in India in living donor liver transplant, and has also set up centers in adjacent countries like Pakistan, Bangladesh, and even Kazakhstan. What I wanted, Subhash, for you to do in this is that talk to the people, to the listeners, that how this journey, this tremendous journey of living donor liver transplantation came about. And we all know that you're a critical part of this development.
Thank you very much. As you know, you were one of my first mentors when I joined Unit 1. And one of the first things I learned from you was to be punctual, where punctuality is not a virtue in India, as you know. We never are on time ever, but you're one of the first persons I learned from you that you have to be punctual. And I think, and of course, when I went to UK, that was reinforced. When you said 8 a.m., it meant 8 a.m. And I'm really grateful to you for not only teaching me the art and science of surgery. In that day, I was just a beginner with little exposure to surgery. And I came into surgery in a sort of very funny manner because the only reason I chose surgery was not because I ever wanted to be a surgeon, but that was the easiest branch to get at that time because all the bright people were going into medicine. So I chose surgery by default because I didn't want to waste a year.
We trained together. We were together for several years through MBBS and all. But what I want to know from you is, where did this transplant journey start? I mean, when did you uh, realize that you wanted to do transplant, and where the seeds of this were sown, and how it grew to the uh, point at which it is today?
I think the credit must go to Professor Nandi, with whom I worked for 3 years as a senior resident. In those days, there was no MCH in GI surgery. And he had two passions. One was portal hypertensive surgery, in which he excelled and mastered and obviously became a world authority. And his second passion was liver transplantation. And
Right.
although he worked very hard to get it going, uh, but at that time, it didn't really take off because perhaps the country was not ready for it.
Yeah.
But what he did for me and for others also, and many of his trainees are in successful positions across the world, he used to have liver transplantation as part of the agenda of academic activity, meaning that there were journal clubs. And also, he was very, very interested in animal transplantation. And I was made in charge of the animal transplantation. All in nature, a very
Yeah.
nice animal house. In all respects, it would resemble a modern day liver transplant operation. So at that time, of course, I wasn't sure that liver transplant is such a life-changing event because I've not seen that many patients after liver transplantation. I thought it was more of a experimental thing.
Right.
But what he did for me was, which is even more, I'm grateful to him for that. He helped me go to England and to Birmingham. And when I saw patients after liver transplantation, the dramatic change in their life, the gift of life, as they used to call it there. And then I said that, yes, liver transplantation must be done. And at that time, of course, I wasn't sure whether I'll be back in India or not, but I thought, yes, liver transplantation is going to be a career path for me.
You mentioned Birmingham, and I think there was a close association of that department with Professor Nandi or so. And what I gather is that was instrumental in your training and developing the interest in liver transplant. So tell me how that stint in Birmingham helped you
So
getting into transplant and subsequently when you came back to India.
I remember there being a German surgeon, and Germany at that time was also one of the leaders in liver transplantation. So it's a surprise to see this German surgeon, Martin Schilling, a good friend of mine now. So I asked him, why have you come to Birmingham? He said that, transplant done all over the world, but in Birmingham, they use such little sophisticated equipment, such little few diagnostic tests, yet have the best results in the world. And he just wanted to see that firsthand. So I think one of the credits to Paul McMaster, who was, of course, a great friend of
Dr.
Dr.
Nandi.
Nandi, because
Yeah.
they both worked together in Cambridge. And that's how I got the job, really. And was that he'd simplified the operation. Everyone had a role and trainees from all over the world. It was like a mini United Nations there, actually. You had everybody from all over the world there.
So when you came back or when you were planning to come back, were you, I mean, in a state of mind, confident that you would be able to establish or that was the career path in India? And, at that time also it was in its infancy year, and especially the living donor transplant. So what kind of challenges you faced to set up a transplant program when you came back from Birmingham, England?
So, as far as cadaveric transplant is concerned, I've done enough in UK, and I was very confident that cadaveric transplantation should not be a problem for me. The problem, of course, was how to get the donors. In
Yeah.
India, at that stage, and even now to some extent, we have not progressed in cadaveric transplantation as much as the rest of the world. And if I were to ask myself and see why that is so, although a lot of people will say that is lack of awareness and that's why it's not happening. But I think the main reason why it doesn't happen is because at the moment transplantation is limited to private sector, whereas government sectors still are not doing enough transplantation. So it seems like activity of the rich. So a lot of people are very hesitant to donate organs, altruistic donation for the benefit of some rich people. I mean, that's my personal opinion.
Hmm.
And unless we have a robust health system where everybody is going to be taken care of, I think cadaveric donation will lack. Maybe you can say it's also cultural because a lot of East, like Japan
Yes.
and Korea, do not
Yeah.
have big
That's,
donation.
that's
Maybe the factors.
yeah.
Uh, but I think if somewhere along the line, if the government was to propose or make a thing that anybody who donated organs would be entitled to free healthcare, even for a short while, I think many more people will come forward for donation. So in the beginning, when I came back from Birmingham, we struggled, I think, for 2 years, struggled very hard to get cadaveric organs. And within the ICU, made friends with the ICU team, with the neurologists, neurosurgeons. And I think Dr. Sama was very keen, who was the chairman of Gangaram at that time, that, it will take off because Gangaram is a close community. everybody helps everybody else. But that was not to be. So then at that time in 97, the first living related adult to adult transplantation was reported by ST Fan and CM Low from Hong Kong. And that was a paradigm shift, I think, in adult liver transplantation. There were some pediatric transplants going on, but nobody at that time believed that you could take out 60-70% of the right lobe without causing harm to the donor. So once that was reported, and obviously that set the stage for what we were to do later on in India.
So you came, you struggled to set up, and then you got on with it and did the initial living donor transplants. So, how was it? I mean, how was the experience? Because there is like less awareness about it or training in that. You had to put together a team. All of them are not at the same, page in terms of training and all. So, do you remember the initial cases and how
I remember very vividly, because obviously all of us were sort of very
taking on a
nervous,
journey? Yeah.
very nervous. But what we did, and of course, must again thank Dr. Nandi, because he set the environment right. We used to have journal club every day. We used to have a journal club for liver transplantation. And luckily for me, we had a very active HPV department, and we were doing liver dissections routinely. So what I started doing liver dissections after having read all the literature that you know how to do donor hepatectomy. So I would do a liver dissection in the same way as I would do a donor surgery. That helped me a lot, because obviously
Right.
you use the CUSA, you got stumps of vessels, and this wouldn't be unethical, because we were actually doing it without blood loss, but we're doing it in exactly the donor hepatectomy manner. And but what was lacking at that time, and this is 98, 99, 2000, this ICUs were not the same as I'd seen in UK. And one of the things that amazed me in ICUs in UK was the nurse. The nurse would watch the patient like a hawk, which is something that unheard of in India at that time. And they would, so we brought about a sort of a working together kind of atmosphere, which is very popular in UK, because they had a morning and evening rounds. We looked at the chart, and then they discussed amongst each other what is to be done next. But I think even now, most of us in India work mostly in isolation, and that teamwork where you talk to each other and come when you discuss things, you always come to the right sort of decision. Whereas if you arbitrarily decide, then you often make mistakes.
So, I mean, again, I bring back to because it was something new, something challenging, which we're going on or embarking on. So, how did you, I mean, convince people to come for this procedure? The initial ones I'm talking of, that, that how did they fare? How was your, anxiously waiting how it would respond, how it would take? So I just want to sort of
I
hear
think
from you because
this was the most difficult aspect, really, of to getting patients to agree to a new procedure. And I remember the first one, and I learned a lesson from that. The first one I was planning to do was a sister who wanted to donate to her brother, who was, of course, very advanced liver disease, and she was a good donor. And I think if we had done that operation, that would have been very good. But the anesthetist went and spoke to the donor and said that this is Dr. Gupta's first operation, and they ran away. They actually ran away. So then I learned that if you want to work together, you must have to have the anesthetist on board completely. And I think this bonding with the anesthetist and the fact that Dr. Nandi had a great influence on patients, And in fact, I would always involve him in the decision making, helped us convince the first few patients to go through transplantation. What we were very careful in those days, and still are, still you have to be, ensure that the donors had absolutely
Absolutely.
no morbidity or mortality. In fact, if that had happened, then perhaps I think we would still not have progressed. But luckily, in the first 10, 20 transplants, all the donors recovered miraculously without any not all the some of the recipients recovered, but not all the recipients recovered. But the donors made an uneventful recovery. So, and of course, the media helped us a lot because every successful transplant at that time was
Yeah.
widely reported. So that helped to bring in more patients.
Subhash, when you started, you had a team, and over a period of time and decade later, you have a big team with a lot of people who are skilled and are competent to do the procedure. What I want to know is that how do you pick up people in the team? Do you choose them or they choose you? I mean, you understand what I'm saying?
Yeah,
You
absolutely.
know,
Yeah.
you pick up the gems and do that, or the good people, the trained people, the competent and technically good people approach you and there's no problem. You just take them on board. How do you make these teams?
So I think the first thing that we look in trainees is that they must be truthful. So if they will not say something that they're not confident of. So I think this is
No
the
fibbing.
not, yeah, absolutely. They are that, and whatever they say, because you run a big program, you rely on other people's opinion.
Absolutely. Yeah.
If they say that he's okay, that means he's okay. And
Okay.
we gone and seen them. Rest of teaching and training, once this basic quality is there, and also the second quality we look in these trainees is that they will not do anything for their surgical sort of ego or for their thought that they can do everything.
Hmm.
They do as much as they're comfortable with. And moment they feel that they are stuck, they'll call for help. If these two qualities are there, then of course, I mean, we all know our Indian surgeons are very talented,
Yeah.
and it's very easy to build on that skill very easily. And over the years, I must say, I've had some of the best people with me from different sort of uh, countries
Backgrounds, country.
and uh, and uh, uh, and they've really turned out to be gems, as you can see in the length of breadth of the country. Many programs in Kerala are run by trainees from us. In Delhi itself, there are at least 6 programs whose program directors were associated with us in the past.
This is one area where you need teams. It's not like it's a liver resection you do or a Whipple, okay, you do and you have some. So you need teams, 2 surgeries are going on and you need competent people. So it's very important that we understand how you've gone about making that team. So I really appreciate the points which you have put forth because I think the trainees need to understand that the value comes from being committed, honest, and have skills, but know your limitations.
Yeah, yeah,
Right.
absolutely.
Yeah.
I couldn't agree with you more.
So let's move on, Subhash, from here. So I just want to touch upon donors, recipients, and some few other things which you have done. Uh, see, the thing which we always find it interesting or challenging is to choose a donor because a donor is a normal person, is doing it out of altruistic motive, and you have a tremendous responsibility of that safety. So we have some standard criteria, we have some extended criteria, and we have contraindications. So can you, for the audience, elaborate on that? And then Another aspect which I want you to talk about is donor consent, that how critical it is, the donor consent. And my question is, who should be doing the donor consenting? Do I as a surgeon do it? Is there a conflict of interest because I want them to agree to do the procedure, and so on and so forth? So can you please elaborate on these things?
Okay. I think the we'll take the donor consent part first, because I think that is really the core of this living donor liver transplantation. Uh, how we've done it over the years is that initially we were much more, what should I say?
Cautious, careful.
No, no, much more encouraging. I must say, I was,
Okay. The-
no, because we wanted to push the program, and we
yes.
were, we would say that, it's safe, you go ahead and do it. But over the years, I've realized that for the donor operation, not as doing a 60%, 70% hepatectomy in a donor is not it's a major exercise. And therefore,
Hmm.
I take, nowadays there's a trend to call donor hepatectomy minimally invasive donor hepatectomy. And I find that an appalling term because, you're doing a 70% hepatectomy and you call it minimally invasive.
Minimal invasive.
Stretch of imagination is that minimally invasive. Just because your scars are smaller, 70% hepatectomy is the
Major effort.
major changes in the donor. And to tell you an incident which really shook me when we were doing a young donor who had, towards the end of the surgery, his temperature started going up. And at that time, we know we couldn't figure out what was happening. But what happens is most of these patients are kept, dehydrated, because obviously when the liver is dehydrated, then when the body is dehydrated, then the liver transaction is easier. Then use a lot of energy device. So temperature does tend to start rising.
Mhm.
This donor then went on to kind of a malignant hypothermia situation.
Oh,
Had it not been for, I mean, what there was such stroke of good luck. We just poured all the ice that we were going to put the liver into the abdomen, and that's
uh,
why I managed to save that person. But it would have been a disaster, really. So it is, in the end, it is it's very, very dangerous operation. There's no doubt about it. But you have to be at all times alert. So as far as donor selection is concerned, if you do a 65% donor hepatectomy, I won't say 70%, you do a 65% donor hepatectomy, preserving the middle vein in the remnant. Don't take the middle vein at all. Stay away from. These donors are going to recover nicely, very quickly. Of course, they will have nausea and vomiting for first 48 hours, and but beyond that, after 5 days, 6 days, they'll be reasonably back to normal. So all these things we tell nowadays. I do it myself, and if and Sadiq, I must tell you that in spite of me spelling out the dangers of the operation, and I keep telling them that, go think about it, come back, because it's not a simple
hmm.
operation. Invariably, they always come back. The
Is it
logic
because of your way of taking consent or information, or is it your reputation?
oh no, yes, I think I actually tell them not to donate nowadays. Actually,
So,
believe
so
me.
that means they have sources of information
Yeah,
other than that,
yeah.
and they are actually committed already to do it. And of course, they know
No,
that
I look at
they're
it in
going
a
to a place.
slightly different manner. They kind of feel guilty that if I don't do it and
Uh,
something happens to the recipient, they will not be able to live with it for the rest of their life, that they did not do enough.
so we know the standard that related age less than 50, more than 18, then, no liver disease, no fatty liver, no other major comorbidities, and good sized liver and all as the thing. Now tell me that have we come to a position where we extend the limits of choosing a donor. And in that, I want to talk about, say, when there is a difficult anatomy, the biliary anatomy, the vascular anatomy, which earlier or in the early phase of development of living donor transplant, we would be wary of taking them. So, how this has progressed in your own practice and experience?
Yeah, that's a very good question. And I think one thing that often is not realized by many trainees and HPB surgeons, that liver actually has two planes. One is on the inflow, which we never calculate. We always calculate based on the outflow because
Right.
the middle hepatic vein is clearly well seen and very easy. You put a marker there and easily calculate the volumes. But actually, the liver is there's also an inflow plane, and if you did a volumetry based on the portal vein branches, and the two rarely match. The inflow plane and the outflow plane rarely match. So remnant liver volumes if you were just strict about followed just on the middle hepatic vein path, then end up, you may end up rejecting many donors. So volumetry you have to do, and again, the other important thing that we've learned over a period of time is that volumetry is not an exact science.
Yes.
For example, for
Yes.
example, give you a left lateral segment which is thinned out and running over the spleen may have a very low volume when compared to, say, a left lateral segment which seems very sort of expanded and full. But the thinned out left lateral segment will regenerate much better in the post-operative period. So I think the key really in the donor hepatectomy is remnant liver volume and the preserving the middle vein with the donor. What that means, of course, is that on the back table, you'd have to spend 1 hour, 2 hours to create that middle hepatic vein. That adds, because I was in Hong Kong and in those days, they were routinely including the middle hepatic vein. But I think all over
Yeah.
the world now, that
Right.
practice has changed completely. You much rather reconstruct small tributaries on the back table. So once you get the idea of this remnant liver volume, and what we do ourselves, we haven't published this, but we presented this in a number of meetings, and I know a lot of people still use it, is where you put a clamp on the right portal vein and measure the change in portal pressure. So that there's no change in portal pressure, then taking that liver out, right lobe out, you probably have the donors will recover rapidly. But that's something that obviously
That's
now it's become,
the table. So
yeah,
now,
yeah.
I mean, like, say, for example, there are biliary anatomy variations in the right lobe, and there are so many variations of the right and anterior and posterior duct and their insertion. And sometimes there's a trifurcation and things like that. Or a hepatic artery, multiple arteries, which are anterior, posterior, and small. So do you have some limitation on that, or you take all comers
Okay. I
with
think
the experience now?
two categories are type of donors we will not take. One is where they have a left-sided gallbladder and you want to take the right lobe. Then it's clearly, you'll end up with difficult. So that left-sided gallbladder and you want to take the right lobe, we'll say no. The
Okay.
second one, where we will definitely say no, or rather three types of donors will say no. The second one is where what we call the type D portal venous anatomy. That means the anterior sector portal vein is coming deep inside the liver from the left portal vein. Combined with this, then there's a with this anomaly, you'll often find that the posterior duct goes and joins to the left of the left hepatic. These donors are really should
Tough.
not be done. But having said that, we recently did a similar one, but where we actually changed the sequence of donor hepatectomy. We actually divided the bile duct first to get to the anterior portal vein, and we were able to successfully do it. But obviously, that is a dire circumstance, but that is to be avoided. And the
Hmm.
third donor, which is again, I think, is a male donor, female donors do much better than male donors in terms of recovery of liver function for some strange reason. The the male donor who has two portal veins and has a borderline remnant, I think that donor you have to be really, really careful. You can get into big trouble. And so these are the ones we avoid. Coming back to your question on biliary anatomy, I think biliary anatomy is really, unless I can't think of a biliary anatomy where I would actually say no, whether there are two ducts, three ducts. It adds to the time. But as long as the remnant is not unlikely to be injured, then we will go ahead. But obviously, you may need to lower the plate, hilar plate, and cut more to the right rather than towards the left. But biliary anatomy, although biliary
Complications.
complications are
Just,
there, we've learned to manage it well.
right.
And I want to share that with you because this used to be a big
We'll,
problem in the
yeah,
past. But now we have a bile leak, we just sit on it. Like in the old days, we
yeah.
just have to keep drinking bile till about 6 weeks, 2 months, and then we can easily stent them, and there's not a problem. But previously, we used to be scared that if there's a bile leak, they'll end up with septicemia and vascular thrombosis. But pure bile leaks, is like in the olden days when we used to treat biliary fistula by delayed operation, it's exactly like that. But they must be taught to drink that bile and they invariably recover. What you need to do, because healing is slow, very, very slow post-transplantation. But if you did an early ERCP or something, you'll introduce infection. Or even if you did PTPD, these livers are very soft and you can cause a vascular injury. So you just really need to sit on it. And then the question was about complex arterial anatomy. Now, this has been shown repeatedly that though as a practice, we would reconstruct every artery just to, and I saw an interesting paper by the Korean group where they reported that 0% hepatic artery thrombosis was they reconstructed more than one artery. So
Mhm.
you're kind of buying insurance if you join all of them. But doing one is just good enough. In fact, I think in liver transplantation a few months ago, one liver, one artery, that was the title of the paper. So the additional arteries didn't really matter. But what is important is sometimes the middle hepatic vein is the main vein of the liver. And I'm sure you must have seen where it's draining the segment 4, 5, 8, everything, and even sometimes segment 6. And these are the donors you have to be really careful of because, that lies in the middle. And any injury to that, the graft will not work because you will not have reconstructed it well. And if the remnant would not work if there's damage to that. So with a dominant middle vein with small right veins or inferior veins, then you really have to be careful.
Of- So just to complete the donor thing, we've addressed most things. But if I tell you that you tell me two or three things about donor hepatectomy where you are most careful and where it has a potential for problems. So what would those be?
Yeah. I think the first one would be that do not believe the volumetric. Look at it yourself because
Have you had to
what
ever come back that it's very less volume? Anytime in your 5,000, 4,000 transplants?
that we abandoned.
Mm,
Well, we've not because but we can change the planned operation.
right,
So, for example, if we planned a right lobe, we can easily change to a left lobe graft.
right,
Or if you planned a right lobe graft, you can easily change into right posterior sector graft.
right.
So
So
you
that's
can change. You
important.
can change easily. So you
That's
should. I'll tell you one very interesting incident. We had a person from Japan who was doing a fellowship with us for a year. So I think I was a bit late in coming to theater. Don't make this public, but he did come late.
we're all learning from you.
So this fellow, had injured the left vein or middle vein junction, and he stitched it, bleeding had stopped, everything was fine. Now I got really worried. I said, if I leave the donor with a stitched left vein, middle
Left
vein, left vein, I mean, it was not clear. There was some, there were like a
junction.
common, it was common. So
Mm,
then I quickly changed the plan. I said, we'll take the left lobe. I said, I'll leave the donor with the healthy side. I'll take the left lobe. And
mm,
I opened it from the back table. The whole, there was nearly 50% occlusion of
oh,
the left. you
mm,
know, then it would have been, although outwardly it seemed everything fine, there's no bleeding, everything, liver's looking soft. But if I'd left him with a stitched left middle vein junction, I would have been in trouble. So you have to be like constantly be alert to all
yeah. And be
situations.
open to change of plan,
Yeah,
as you
yeah,
said. So
yeah,
don't
yeah.
believe the
Parliament.
volumetry and assess on the table.
Yeah, yeah. So that, and we can we can do as I call you can go along the inflow plane, and if you go along the inflow plane and keep the middle vein nicely covered all throughout, you will not have. I mean, any HPB surgeon will tell you that taking out the right lobe without disturbing the middle vein. I mean, very unlikely that you're going to have a problem, isn't it? Or you may
Right.
have some problem with anti-sector congestion, but
Yeah.
you will not have a problem with the donor. So that is something that is. So that's one assessment yourself, seeing that the right lobe. Uh, the other area where I said was a young male donor whose remnant seems borderline. Then again, you have to be really careful because some of these they recover their liver function quickly, but sometimes they end up with pancreatitis. And if you look at the mortality after liver donation, some of the mortality has been attributed to pancreatitis. Of course, many
Mm,
people say that is because of cholangiogram and dye going
mm,
into the pancreatic duct. But I think it's more than that. I think in
yeah.
the similar way, there
Has
may
to be
be
more to it.
more to it. There has been, you can look at all the donor model, they've been labeled as pancreatitis. But
Mm.
I think the low remnant contributes to this pancreatitis. And young male donor, the borderline remnant, you can end up with pancreatitis. And you can, what we call, you go along the inflow plane and you will, end up giving them a good remnant.
What
Then
about
I think,
bile duct transection?
yeah,
You
bile
have
duct.
some techniques of that,
Yeah, yeah.
minimize the biliary
Yeah.
complications.
So I think the biliary division is in the beginning we made some mistakes, and I published on that as well based on our mistakes. But in those days we used to do open sort of so we always had a cystic duct patch. So if I was ever in doubt, I just the put a patch on the remnant bile duct. So you made a elliptical. It's always well vascularized and gave it like that. But so that is in case of doubt. Of course, it's not a situation one should get into. But what for the techniques that we've learned is that you must lower the plate. If you lower the plate, then there's a vein that goes between the two sides, small vein that goes between the right and left bile ducts. You must identify that vein. So then you will not injure it. Then second, if there's a posterior duct, then it's the best way to cut it is by first dividing the anterior duct, put a probe in it, and cut along the probe far away from the left duct. And these simple things can save you from trouble. As long as the remnant is not affected in the recipient, you can do many things. If there's a difficult posterior duct anastomose, because we use high highlight dissection, you always have sufficient length of bile duct to join in. And of course, these cases will have bile duct because the anastomosis can never be perfect. But you just sit on them. You don't rush to do a procedure. And uh, believe me, I'm not, and we have huge experience on this now. Most of these bile leaks will either settle or at 6 weeks, 2 months, if they haven't settled, you can deal with them with ERCP or with PTP.
So at some stage, there was a lot of thing from your group and others to minimize the complications in biliary in recipients. that you don't denude the bile duct. You take it with the plate so that it all remains in one, and you
Yeah.
don't necessarily have to do a duct to duct, but to the whole
Yeah. Yeah.
cranium. So
I think that technique is important, but for to do that, you have to loop it completely. And the one way to loop it completely is that you go down onto the caudate lobe, and there's some tissue on it. And once you divide the caudate lobe, and you can actually, we have completed the transaction, your right angle will come on top of the uh, bile ducts of the two sides. So you can then loop it and cut it nicely. But over the years, I think we've changed practice, because sometimes with this, you may end up injuring the posterior duct or even the sort of remnant side. So if we suspect, if there's a single duct, this technique works beautifully, and you get a nice, beautiful stump with sort of all the plexus around it. And these, of course, these recipient recovery is good, biliary complicated few. But when there are two ducts, I think you have to be a little bit careful, ensure that you cannot loop the entire complex easily. So one would divide the one duct, probe it, and then cut the other one.
So, Subhash, I just want you to briefly talk a bit on donor mortality. It's
Yeah,
something
I
which we don't want. It's a very serious thing. But we also know that these have occurred across the globe. So, what is your, take on this? That A, you've of course highlighted a lot of things by which you could minimize that or make the donor safe with change in plans and all those things. But you know, how does one take this mortality? Say, I'm doing a program of the living donor transplant and I have a mortality.
This is a very, very difficult question, but I'll answer it with honesty, and you know, it's not something that you can come to terms with. It's a disaster, complete disaster. And you'll be in grief and mourning for months after that. So let me first take you through the first donor mortality we had. And that shook me, really shook me. This was a lady who we didn't realize at that time, who was donating for her husband. And much later, it came to me that she had been turned down as a donor by another center. We were, as I said earlier, we were a little bit more encouraging. We used to encourage donation more in the past. I actually don't encourage donation now, but
Hmm.
still they want to donate. So this lady had had chemotherapy, radiotherapy, and all the facts was hidden from us.
Oh.
Up,
Hmm.
in India, there's no record system. There's a patient from Calcutta. I still remember it. And in those days, we were very gung-ho about taking the middle hepatic vein. That was where after that, I made the change, that middle hepatic vein. So she had very smooth recovery. And I think on the eighth or ninth day, she went to the washroom, collapse, and she had a subarachnoid hemorrhage. And then she stayed. We tried to make her better, really involved in neurosurgery. But at 6 weeks, she died from this subarachnoid hemorrhage. So what I realized at this stage was that the first time I realized that hepatectomy this magnitude is a major sort of
Undertaker.
stress on the body. You know, so after that we made a change that we will not do any grafts with middle hepatic vein, even if it takes long time for reconstruction. The second time it happened was when we were doing again, people. This one I haven't sort of published it or written, but we were just beginning to start doing minimally invasive donor hepatectomy, laparoscopic robotic. And because we'd already done so many, there was some bleed from the inferior hepatic vein, and we thought we'll tackle it, and we just didn't take it seriously. That boomeranged into a terrible situation. And of course, there was a lot of question answers from the hospital, from the administration. but luckily, because the way I consent, the family was okay with it. You know, uh, they did not. We told, even in the middle of the operation, one of us went out and talked to them that, this is something that is unexpected that has happened. And but they didn't take us to task for it. They were, I mean, very nice to us. But the hospital, of course, took a very serious view of it, and then we had to make some changes in the. That was a technical misadventure. Then we've had two other donor deaths, which is rather strange because they happened much after donation, and they're from suicide. So these are the four, and I don't know what is the answer to that. But if you look at the sort of literature on donor morbidity and mortality, you'll find that donor suicide rate is slightly higher than that of the
Mm.
rest of the
Yeah.
population.
I think that assessment, psychological assessment is an important component which we put it and tick it, but I
Yeah.
think it has to be done seriously. Subhash, do you think there is any correlation between these kind of uh, like suicide and all with respect to recipient outcome? If the recipient
Let
outcome
me
is
discuss
good or
the
bad?
first suicide that I got to know. This is a lady girl who had donated to his mother. And years later, she fell in love with her mother, with a boy, and the mother would not give consent. So she got so angry that
Mm.
here I've done so much for you, you know. So that was one. The second one was I think probably the donor felt that he wasn't being rewarded enough by the rest of the family, was not given due credit for what he'd done.
Serious uh,
Yeah.
risk
So
that
these are two.
yeah.
One of the good things of our program is we are like a family. They'll ring us up for even small things, and everyone from our department, is they'll pick up calls at any time, and so we kind of know everything about what's going on in their life, even till sort of 10 years, 20 years, post transplant.
But thanks for sharing and telling how difficult it is when you have this. But these are problems and complications. There is always a potential, and you need to. That's why have a good consenting and take care of the problems and deal with it if it happens. It's really very illuminating and informative to just discuss out, because I'm sure this we are not going to get from textbooks and journals. These are personal experiences. But I want to move to recipient now, who's the core of the transplant thing. We know that indications, all the things are well designed. You can make out who's a sick recipient, acceptable recipient, so on and so forth. And also, we now know that people with experience have expanded the indications for transplant and taking up more sick patients. So I'm not going to ask you who you will take for transplant, but who will you not take for transplant? Which patients with liver disease are in your book unsuitable for transplant?
So let's look at three categories. One is malignancies, and anyone with sort of extrahepatic malignancy or portal vein tumor thrombus, even if it is segmental or subsegmental, will generally not take up for transplantation because otherwise they will have recurrence. And so this category, even if the downstage brought within the category, we as a group are very reluctant to do this. But having said that, I have had on there will be special occasions where you will have to do it. And I can recall a situation where we had a young person who was, I think, not married, but he had a girlfriend. He was in from, I think, northeastern India. And there was some pulmonary tumor thrombus, and he was in sort of renal failure and everything. So I said, he's not a transplant candidate. So his family came to me. I said, even if he lives for 2 years, I want him to have the transplant because I want him to get married, have a child, and then go.
Mm, mm,
So what I'm trying to say is that you can't sometimes make absolute rules and just stick by it. So we did transplant him. He got married, has had a child, and then 2 years later, obviously, he died from recurrent malignancy. But the family is still now very, very grateful for having listened to them. But
mm.
by and large, we'll discourage in this category. Second category is
But,
acute liver
let me
failure,
just ask one more
where
question about malignancy. So we have these criteria, Milan, UCSF, and then metro ticket, and so on. But from what I understand is there is no line drawn there also, and it is individual decision making on taking intrahepatic tumors where there is still lot of flexibility. So do you also conform to that? You said extrahepatic and vascular, but what about
really how we
beyond the criteria?
that is complete no. Within the liver, if the liver functions are good, then nowadays downstaging or treatment for liver malignancy, which is within the liver and not liver functions are not deranged, you have a lot of options.
So one you said is malignancy. Then what other you won't take for transplant?
So ALF. ALF is what we see nowadays is uh, that some of our ALF patients who we, unlike paracetamol overdose, I think many of these patients their cerebral edema will not recover after transplantation. So these are patients you have to be really careful of. They may fit the criteria for transplantation, but interestingly, many of them will actually also improve, even if they have an INR greater than 10, they'll actually improve on their own. And one of the criticisms I have nowadays of people who are doing plasmapheresis for ALF is that you lose the most important prognostic factor for ALF, which is INR. Because you're giving them an AFFP, how are you going to monitor whether they are
True.
improving or not improving? So that's something that I think we really, as a nation, as a group, you need to have strict guidelines. Everyone's doing plasmapheresis because, and thereby you deny them the chance of, monitoring and recovering them. The third thing that in ALF, of course, is if they are fixed dilated pupils are also not such a contraindication because, inotropes and all. But if these patients have sort of multi-organ dysfunction with inotropes and renal shutdown. These patients will do poorly after transplantation. I'll tell you the ones we will not do, where encephalopathy has been prolonged. I've not been able to assess because they will never wake up after the operation. Those who have had respiratory, we calculate the PaO2 FiO2 ratio, which is less than 200, will not do. And of course, those who have mucosal GI bleeding, not varicose bleeding. And, if you have varicose bleeding, obviously it'd be hypotensive, but
Yeah.
that is very different from mucosal GI bleeding, which we all know nowadays. Patients in ICU, they invariably end up dying from mucosal GI bleed, which we call it DIC or whatever. But that's because every part of the body is ischemic and there's no point transplanting
Mm.
them.
Yeah. Uh, I'm also aware of the fact that there are a lot of innovations which your team have done to improve the outcomes of patients with liver disease or the recipients who are undergoing transplant. So, can you just elaborate on this, that how and what innovations and how they've impacted the outcome in your patients?
So this is a very nice question because we really done a lot of work on this. And would you want me to speak on all of them or just one or two? Because this is a very
What
favorite
you
topic
think
of
are the important or major ones which you
mine.
think have made an impact
So
on the
yeah,
outcome, change the
yeah.
outcomes of
One
the.
thing that I'm very proud of is that a very simple test that you do at the start of the donor operation, which is you clamp the root of the middle and the left vein, and you
left.
divide the right artery, and you clamp the right artery, you can see the entire extent of anterior sector, which is being drained by the middle vein. So that gives you an idea how important the middle vein
Much.
reconstruction is going to be. You can do it with some software, but the software will not take into account collateral connection. It just looks at a vein and
Yeah.
estimate area around it. So I'm quite proud of this test because it actually, I mean, if you have not done it, then you should try it and do it. And, you can see it clearly delineates how much of the
Congestion.
is being drained by the middle vein and how vital middle vein reconstruction is going to be in that. Then we introduced, we used to get a lot of small babies with, less than 6 kgs, malnourished, fragile, it's a lot of ascites, and in them fitting a liver. And of course, the Japanese, my friend Morio Kashar introduced that monosegment graft. But we went on to describe the medially reduced graft, which reduces the thickness, but actually also gives you a good length of vascular stumps, and you're able to close the abdomen and extubate them at the end of the surgery,
So
which is, I think,
medially reduced means, can you just elaborate what?
medially reduced means that in the standard left lateral segment graft, you either, if it's big, you reduce the lateral part of it, or you reduce the inferior part of it. You keep the falciform ligament intact. But
Right.
actually, what you do in this is that you start your transection at the beginning, where the left hepatic vein is. You mark it there, and then you extend that line below upwards, and then you take down the falciform ligament to all the segment 4 branches, 4A, 4B branches. So you end up with a graft which is without the falciform ligament, and it's not only reduced in volume, reduced in thickness as well. So that has, I think, been, of course, the is not we've not been able to popularize it as much because the I don't want to go into the reasons, but try it out. It's amazing. I know lots of surgeons do it routinely now because they own up to me, the saying that we will use your technique works well, but it is a fantastic technique. The second important thing that we introduced, and that has given us a lot of credit, is this GRWR business. If it's a 150 kg man, you cannot do a living related transplantation. We have shown nicely, and it has been sort of applied elsewhere, that once you cross a certain volume, this GR ratio is immaterial. And
Okay.
I was in a lecture in Georgia about in a liver session, and the chief of transplant surgeon in Pittsburgh, who does living related transplant, he said he follows my dictum. So that was quite reassuring. So we put a sort of death knell on dual lobe transplantation. And I think these are some of the major ones that really come to my mind that we've done. Of
Yeah.
course, we've done many on other things, but these are 3, 4 things that has really made an impact on living related transplantation. And
Uh,
one other thing that we've done recently, this is the last 2, 3 years, is that the hepatic veins that we are doing, we now do it with a growth factor. That has given me peace of mind. you
Okay.
know that is, you always scared that there'll be air embolism or something, but you do it nicely. The entire growth factor, how big it is, will be taken up by the anastomosis. We used to do it for the portal vein routinely, we
Yeah.
never did it for hepatic vein. But that again has been very helpful in reducing small foot size syndrome.
So we are finally coming to the end of our this thing, Subhash, and now the inevitable question is that there are so many people who want to be transplant surgeons. There's so many people who want to emulate you and also go ahead more than that. Uh, what do you think would be your advice to these people if they're embarking on a career in liver transplantation?
My advice would be that stay in a good unit, large volume unit, for a couple of years, 3 years, 4 years, till you think you have sort of mastered everything. The problem with the liver transplant surgeon in India, even now, is that the liver transplant surgeon is not just a surgeon. He has to be a bit of an anesthetist. He has to be a bit of a critical care specialist. he has to be a bit of a hepatologist, he has to be a bit of
Right.
an immunologist, and he has to be a
Yes.
bit of infectious disease person. And that surgical skill you can learn in 6 months, 1 year. But if you don't learn the other things, then your program is going to be in difficult. You cannot, the lead person, the captain has to be aware of all, he has to have a working knowledge of hepatology. He should know, you know, and that's, I'm fortunate because in Birmingham, where it was a combined unit, where all the hepatologists and the surgeons, and they did a combined round, I picked up many of these things from there.
And also the amount of time you have to invest in this, you have to be prepared for that, long
Yeah.
hours at work. Uh, so, I mean, I think, we come back to the same uh, issues that commitment, passion is what you need for doing such a kind of undertaking. Uh,
So I think what has happened now is everyone talks about work-life balance.
right.
I think Ratan Tata once said that actually it is work-life integration, not work-life balance. So as long as we believe in work-life integration, I think we'll be fine. But if we look at work-life balance, then I think we are in problem because I find young trainees now who want to be off at 5 p.m. And I think medicine just doesn't work that way.
I would like to hear, since in a summary manner, your tremendous work over these past a decade and a half on living donor transplant. Just a summary that uh, 4,500 liver transplants over this period, uh, 350 to 400 per year. And could you just briefly tell what your results are?
We do a weekly audit. And interestingly, in the last 1 year, 2 years, we have less than 10% mortality, although we are taking up very, very sick patients nowadays. Uh, the 1 year survival is over 80% now. And we done some audit where, we went up in the process of writing a paper on 10-year survival after liver transplantation. And it is 70%, 10-year survival.
So, Subhash, what I would like to say is it's really an amazing, amazing journey that you have had to establish a program with such high volumes, to be counted amongst the best in the world. And you've put India on the map for living donor transplant. So, I I really congratulate you. I feel happy and proud to be associated with you, and I'm sure that this uh, your experiences which you have shared today would help a lot of people to sort of understand the complexities of this difficult procedure and undertaking that you do day in and out. Uh, and I'm sure it will inspire a lot of people to take up this challenge. And we always expect the next generation to outdo the previous one, and that's what we would like and expect. So thank you once again for being part of this podcast and sharing your experiences and results.
Thank you very much. And I've really enjoyed speaking to you. And I know I've always had you in great respect for teaching me from day one of my surgical career the importance of being punctual. Thank you so much.